Okay, so there was a lot of discussion out at the break, and it wasn't about the coffee. It was about virtual trials. Good stuff. Okay, so this session, we heard a little bit about, obviously, we heard about some devices and clinical care. We've heard about observational studies and what that can look like in terms of data collection. So now the opportunity is for lessons learned on interventional virtual clinical trials. So we've got a couple of great speakers here, different perspectives. Steve Cummings is going to talk first. And okay, we've already heard his name a couple of times. He's been on the slides. He asked a question. But Steve is joining us from San Francisco Coordinating Center. And then we have Wendy Weber from NIH. So again, some different perspectives here. And then Kim Hawkins from Sanofi Genzyme. So up to you if you want to use the podium or the table.
Podium.
Okay.
Thanks, Clay and the committee for inviting me to talk. I'm going to talk to something called direct-to-participant trials. I have no financial interests in a company or other. So, I'm sorry? Oh, I'm sorry. I tend to speak softly, so please wave your hand if I'm too soft. Sorry. I'm going to talk about direct-to-participant trials, which I'd like to define very specifically as having no physical clinical sites. That means no geographic limits on recruitment. Not virtual. I hate the word virtual, because in these we're dealing with people who are real and want to build relationships in order for these to be successful. And I don't like the term internet-based because we don't necessarily need internet technology for trials like this. So that's why I prefer that term. And I'm going to tell a story of 3 trials in order to make 2 lessons. One about the importance of simplicity and the other in the importance of the patient's perspective. So let's start with KALM. The history, I think, of KALM and maybe of so-called direct-to-participant trials starts, I think, with Susan Love, who's a breast cancer surgeon who has an army of women. I know that there are 2 women here who are part of it, maybe more. Okay. It's an online army that wants to do research, and she came to a few of us and asked, how can I use my army to do online trials? And so we thought about that and formed a little company called 1747 that got $900,000 from Lilly eVentures to conduct a proof of concept trial that we decided to use, herbals, kava and valerian root versus placebo for anxiety and insomnia. Enrolled patients with anxiety and insomnia, I qualified, had few exclusions, and the endpoints were improvements in all those scales. Well, the elements that we put together for KALM was one center with participant-facing EDC and a website, no paper. The identity was confirmed using a typical service that used public data to ask you what was the make of your first car. Patients established online e-signatures, and we, I think, developed electronic online consent with a quiz to confirm that they understood the trial. All this was approved by WIRB, Western IRB. We managed to study drugs with FedEx delivery to patients with ID confirmation. And we recruited with ads on websites along with emails to friends and relatives. It was a simple trial. We'll come back to this metric. It had 15 screens and less than 10 steps in order to enroll and be randomized. Okay. In 8 weeks, we screened 1,500 patients. 391 were randomized from 45 states. There was actually over 85% adherence. All groups improved in anxiety and sleep. Even the placebo group by about 20-25%. I got a placebo. I sure felt better. But there were no significant differences. But because there was no paper, we were able to analyze, pre-planned, all the data results from the trial within 1 hour, the last day that the data was entered, and we sent individual results to participants, as well as the results of the trial within 1 day. The cost of this trial, Lilly's investment, was about just over $3,000 adjusted for inflation. Well, Lilly then adopted our technology. They took it in-house for a trial of Cialis, and it was run by operations, regulatory, legal, and data all got involved. It became very complex. They decided they needed sites to confirm ID and to do consent, and they called it the most expensive trial per patient we have ever done, and they abandoned the model. So now let's move to remote. You've heard quite a bit about remote. I'm going to tell you a story about remote from the inside of the trial. Let's see. It was about 2009 that Dr. Jeanette Brown, a urologist, and I and a couple of others proposed a simple trial for overactive bladder that we thought would use just one 3-item questionnaire that had been validated to identify and enroll patients with overactive bladder. And we decided to test that trial in part because we've been working with Andy Lee that I had known for a decade, and he actually tried to get into the KALM trial, but couldn't because he wasn't sufficiently anxious. That changed, I think, when he joined Pfizer. He helped design, promote, and secure funding from Pfizer. And then he left, moved to Genzyme, and I think the idea of the simple trial moved with him. So Pfizer's goal became to mimic a clinic site-based trial for OAB of the sort that they had done in the past. And the trial became run by project management, ops, regulatory, security, legal, and probably a group or two that I don't remember. It got FDA approval, a bit about that in a moment, that allowed them to ship study drug to home, which was a variance that the FDA had to approve, which was cool. So there was early support for this whole concept from Bob Temple. Many of you know Bob as a source of innovation. Way back, as he knew about the KALM trial and as early as 2008, started assembling people within to meet within FDA about this concept and gave us quotes of the sort that you see there that were very supportive, and I think encouraged Pfizer to go down this route for approved drugs. Well, the remote process had all of the elements that I mentioned of the direct-to-participant trial, a single center that was run by Mitris, web-based recruitment, and all the other things that you see there was was approved by the Western IRB. But to replicate the site-based clinical trials resulted in a very complex protocol. And it was hard because women with OAB may not be internet savvy. And it's not like a Parkinson's community where people are really sick and and need a cure. And the protocol had many steps. At our count, from the person who developed the system, there were over 100 screens that the patient had to view, and that there were over 90 interactions that our site staff kept track of in order to get the patient randomized in the trial. Some examples of things that people had to go through. First of all, there were prescribing rules that still are problematic that limit recruitment to 9 states. Some required physical examinations in order to dispense the study drug. And those were done by contract doctors, not the patient's own physician, and patients sometimes found them rude and had to wait a long time. Secondly, to prevent hacking, according to the IT group, patients had to get an e-signature that required capture recognition and 2-factor authentication with a time limit. There were many laboratory tests and stringent exclusions, including excluding just bacteriuria without pyuria. During a run-in on 2 days, people had to carry a plastic hat around with them to measure their urine volumes and enter it into a cool mobile device, which unfortunately an error meant that the patient couldn't change that and they were excluded from the trial. And during part of the trial, because of the small variances in the consent, our staff had to read the full consent to patients over the phone, even if they'd already completed the e-consent process. Those are just some examples from the clinic's point of view of the trial. Well, we used web-based recruitment from many, many sources. This was tough. Craig, I don't know how many companies were brought in, at least 10, maybe 15, to try to help us with web-based recruitments. And 20,900 viewed the introduction, 1,500 were eligible and interested. What happened to them? We lost 44 to 84% of women at each one of these 5 steps. And that meant at the end of it, those 1,500 who were initially eligible and interested resulted in only 19 or 1.6% of those actually made it through all those hoops to randomization. Well, was this a recruitment problem? You hear that remote failed because of recruitment issues, but if 25% of the interested and eligible women could have avoided or gotten around or not had those hoops, the trial would have achieved its goal of 283. There was also a lot of worry about an FDA audit, so we had in our clinical site 1 to 3 site monitors at various times. At least a site monitor was there for much of the time during recruitment and enrollment, and despite the fact we had no paper, they asked us to print out web data entries from the patients and emails that had to be redacted with black ink. And at the end, we had over 20 binders of paper printouts about different participants in the trial. So now let me contrast with one other real quick example, a trial in children and families with autism. The medical PI of the remote trial, Steve Bent, was not deterred by the experience and went on to do a simple trial, pilot trial with the Interactive Autism Network. It was a trial of omega-3 fatty acid for hyperactivity. There's really nothing you can do for autism. And so the families in the Autism Network were really thrilled to be part of this study. And within 6 weeks and 864 emails to families, 127 of them responded, 96 completed informed consent. He got 57 kids and their teachers to participate from 28 sites randomized with 100% completion. And he was really gratified to get several messages of thank you from people who lived in rural areas and had no opportunity otherwise to participate in research. So now the last example, it's not yet on the completed list. This is something that's funded by NIA now. We're in the midst of putting it together, hoping to start recruitment in the next couple of months. We have applied the lessons we've learned from the other trials we've seen to design a trial with an FDA-approved drug that has to be given intravenously. In this trial, it's based on the fact that fractures in Parkinson's patients are common. We estimated about a 10% annual risk of fractures due to multiple falls, forward reflexes. And the goal here, or the purpose of the trial, is to test a bone drug, zolendronate, that improves bone density to determine whether, even in this population with multiple falls, you can use a drug like that to prevent fractures. It's a big debate in our field. Some people say, no, you got to prevent the falls. Others say, you've got to strengthen the bones. We're going to resolve it with this trial. But one IV infusion of zolendronate lasts at least 2 years. So we're taking advantage of that fact. And this is an FDA-approved drug. It has to be given intravenously, but it's generic. It became generic about 2 years ago. So in this trial, we aim to recruit 3,500 participants with Parkinson's over the age of 65. Because that's one of the largest interventional trials that's been done that we've heard of, we will need nationwide recruitment that is not limited by sites or practices. We partnered with the Parkinson's Foundation, and I'm pleased to have met Ray here, because now we might have another partner in Fox. And to both get the patient's view as well as being a recognized names to sponsor that the patients might be attracted to or trust. There are no clinic visits. It's entirely conducted from the patient's home. Patients love it. As your surveys indicated, Ray, 90% in a survey said that they really like this home-based design and want to participate. And in particular, patients with Parkinson's are disabled. Some of them have cognitive impairment, and those are the patients most likely, we believe, to benefit from this intervention. And so that's why it needs to be based in home. So we've got a multidisciplinary team, and there's home. That's where this is going to be based. This is how it works. There are 3 touch points for patients, only 3. We have simple criteria with very few exclusions, and we use recruitment sources, the foundation's community, health systems, most of which come from PCORnet, and then Parkinson's neurologists who are also cryolists who have large populations of patients interested in participating. We are not using web-based recruitment. Our experience, including other I didn't talk about, has been disappointing with web-based ads. But we are making sure that they are being recruited by people or institutions they know. The foundation has a call center that will do the initial e-consent and eligibility screens. And then there's a teleneurology examination where a specialist connects with the patient's devices at home in order to do the interviews and observations to confirm the diagnosis and rate its severity. That's step 2. And if they are confirmed, then a nurse visits home, where a finger stick is used to check the GFR, and the patient is given either IV zoledronate or placebo. We follow them up by surveying the EHRs for those who have them, or with a call or postcard every 6 months to participants about the occurrence of fracture. This budget is $9,150 per patient. I hope that Adrian talks about adaptable, because I think that that's another success story. Comparing 2 doses of aspirin, a simple protocol, recruiting from PCORnet EHRs, and has enrolled 15,000 of their 20,000 goal. Okay, so let me summarize. I think the methods for these, and I call them direct-to-participant, please don't call them virtual trials, are well established. We've got a big toolbox. Simplicity for the patient's point of view, is essential. Recruiting from communities and providers that the participants know we believe, data is still needed, may be more successful than recruiting from the web. And I think it would help us reach more states if prescribing laws could change so that we could ship study drugs like this across more than 9, 10, 12 states without having physical examinations. So with that, I want to thank the pioneers, I think, in this effort over the last 15, 20 years. Susan Love, her foundation, Brad Jacobs, who's been with me along the entire time, Steve Bent as well, Andy Lee, who I think is one of the more innovative souls in this field, I've worked with for 15 years, who has ended up as Merck's worldwide COO, Anthony Costello, who built the technology for Mitris, and particularly Bob Temple, that I've been talking to about this and other innovations for years, and I think he's just been a creative, stimulatory force that's permitted things like this to develop. So thank you, and thanks for having me.